Good morning, everybody.
Morning.
Thank you for joining us. My name is Les Jones, and with me today is Rebecca.
Hi.
Rebecca Dunstall, our clinical specialist. Thank you for joining us. We're going to be talking about the safe and appropriate use of functions and accessories in specialist seating this morning. The format is going to be a series of slides, plus we come back to do some practical with some of our seating products to demonstrate some of the theory that Rebecca is going to be talking about. If I leave Rebecca to go and get ready to set up, just a little bit of housekeeping for virtual housekeeping. As I said previously, the mic and video should be switched off. We are recording the session. If you've got any questions at any time, if you want to use the chat function, and our colleague Jess is monitoring the chat function, and we'll try and pick up as many questions at the end of the session. After the session, you'll be getting a virtual pack, which will include copies of the presentation, plus a link to a recording of the session as well.
Anything else we find that could be quite helpful as well?
Yeah, we may well pick up on issues during the presentation that we'll come back to on in a bit more detail with the follow-up pack. So I'm just going to pass you across to Rebecca. And you'll see me in about 10 or 15 minutes when we start to look at some of the theory in practice on some of the products here. Yeah,
we are going to kind of be flipping between theory and practical. So just bear with us as we load in some of the presentations. As I said, I'm Rebecca Dunstall. I'm clinical specialist at Careflex. I'm a physiotherapist by background. And I was fortunate when I graduated that I specialised straight away into learning disabilities and neurology. So postural management has been a key objective of mine with the individuals I work with throughout my clinical practice, and that's where my passion for specialist seating comes from. What we're going to do is kind of split up into three parts so that we can flip between them quite easily. So I think it's helpful to be able to visualise and put into practice some of the theory that we're covering. First of all, just a quick recap, really, setting the scene as to why we wanted to do this webinar today. And it's really, I mean, specialist seating itself is quite a complex topic. There are hundreds, and if you're thinking about our tailored solution service, even thousands of different accessories and setups that can be prescribed for the individuals that we work with. We're obviously not going to cover those thousands in the 45 minutes that we got with you. So what we're going to have a look at is really some of the key functions and accessories that you could come across when working with individuals, some of the top hints and tips, the things to think about to really ensure that whatever we put in place is safe and appropriate for the user. Every chair must be set up to fit the individual. If it's not, they can actually cause more harm than good. We need to support posture appropriately, whilst also ensuring maximum contact with the support surface to distribute the weight as equally and evenly as possible, while still maintaining comfort and independence. It's critical that any seating prescription that we put in place, any care plan, and the setup is based on the individual's body shape and size, which would be determined during the comprehensive seating assessment. Because as I said, if it's not, then it can cause more harm than good. And Les's favourite term to say is that
the devil's in the detail.
That's right. Yeah. The way in which the chair is set up will influence positioning, which can of course then have an impact on the risk of secondary complications. So I'm thinking about things like postural deterioration, pressure injuries, and reduced quality of life. The key principles of seating that we follow here at Careflex, everything that we're talking about during the webinar this morning really ties in these key principles and the objectives that we're trying to achieve with the prescription. It's about thinking holistically about the individual. And here at Careflex, our top priority has always been comfort. Because if the user isn't comfortable, then they're just simply not going to use that piece of equipment, regardless of the clinical benefit that we are trying to portray across to them. So it's really key that an individual is comfortable within the chair. Remember, this is subjective, so we have to communicate with the individual, with their support network, to understand how they portray that comfort if they're non-verbal, for example, if they're using gestures, key facial expressions and so on, if they're unable to verbalize that comfort. Secondly, we have function. Now, the pelvis is the foundation for good sitting posture, because the freedom of movement that we need in the upper limbs to be able to engage in functional movement is achieved through that effective stabilization at the pelvis and the trunk, because whatever happens at the pelvis dictates what happens above and below to those body segments. Pelvic stability can also help to normalize abnormal muscle tone and reflexes, which in turn will obviously help with any related pain, whilst also encouraging as normal movement as possible. Posture management is about ensuring that we support all the body segments to reduce the risk of body distortion and all the nasty secondary complications that can come with that. Things like pain, poor physiological function, ill health, hospital admissions, contractures, the list could go on. And then lastly, we have pressure care, and we'll cover that at the end in a bit of a practical way at the end of this webinar. But what we're aiming to achieve with specialist seating is equal weight distribution over the maximum surface area in simplest terms. Okay, we always like to bring it back to the basics of seating prescription and chair setup, and that is the measurements of the chair itself, because this is what will ensure that we're supporting the individual appropriately and not actually causing any postural challenges. And when we do the practical, you probably see this a bit better. But essentially what we're looking at is seat depth, seat width, seat height, armrest height, but then also the back angle that is tolerated by the individual or that is appropriate for the individual, the tilt and space angle, and also the leg rest angle. So these are all the measurements we need to think about during the seating prescription and then going forward with the care plan, because some of these angles we might need to be really prescriptive with, because if they're using appropriately, they can have a detrimental effect on the body. And of course, these are all guidelines, because every measurement we do will be dictated by the size and shape of the individual and the postural challenges. For example, we're thinking about, if we've been really prescriptive with seat width and we're looking at the width of the pelvis, actually, if we're working with individuals with a windsweeping deformity, then we might actually need to increase that seat width from the widest part of the opposite knee to the opposite hip. So it's just be mindful of that. But that's of course something as clinicians, as healthcare professionals, when you come to a joint seating assessment with the likes of Les and the team, you'll be working together to have a look at those measurements. We've also got extra videos on the website as well, the looks at how to measure individuals.
Yeah, we won't be telling you how to measure this morning. It'll be just how we adjust the chairs to accommodate the individual. We've
got those videos, and if anyone needs those links, then we can put those when we share the presentation as well. So seat depth. A chair with the right seat depth ensures pelvic stability because it supports the pelvis posteriorly at the back. Without that posterior support, the pelvis can tilt backwards and encourages that sacral sit-in with a posterior pelvic tilt. If the seat depth is too long, then the user just simply won't be able to flex their knees over the edge of the seat. They'll have to slide forward in the chair to support the feet, to get that support through the feet. And when we have a look at that, we'll illustrate it
in real life.
So when it's set correctly, the individual's pelvis will be positioned at the back of the chair. Of course, this is gold standard, and we know we work with complex presentations, and sometimes there's a bit of a compromise, and it's just about achieving the optimum position for them. But what we do trying to achieve is that the individual's pelvis is positioned at the back of the chair. But then there's an approximately 2-finger gap then at the back of the knee and the front edge of the seat. And again, some of the videos that we've got available can go into a bit more detail on this as well. Seat width adjustment is what helps to laterally stabilize the pelvis. If we've got correct seat width, then what it can do is reduce the tendency for the individual to lean or shuffle the pelvis within the chair. These undesirable movements can then result in a pelvic obliquity. So that's where one side of the pelvis is higher than the other, or even a pelvic rotation, where one side of the pelvis is more forward than the other. and then the posture becoming increasingly unstable. And what we also have then is unequal loading of tissues with high pressure areas, increasing the risk of pressure damage. If this is left unmanaged, then that leaning posture could then develop into a scoliosis as well. And we could get then these really complex fixed postures that are sadly irreversible. Chairs with adjustable armrests. So I think Les can show you a bit later on something like the multi-adjust, where we can utilize the armrest to be able to set different seat widths from front to back and left to right. For example, if you're working with individuals with fixed lower limb postures, like wind sweeping, or even those with maybe an increased body mass to accommodate the gluteal and hip areas as well. But again, we'll everything that we do in all the theory, we'll put into practice when we look at it shortly with the chairs. Then we have seat height. So this is important for maintaining independence and function for individuals who are still ambulant or those who are still able to rise to standing for transfers. Because simply if the chair height is too high, then they'll be unstable when they stand up. But it can also cause a posterior pelvic tilt because they'll seek that foot support, that proprioceptive feedback through their feet. And likewise, if the seat height is too low, then they may not have the adequate strength to be able to complete the sit to stand. It's also key, even though we're talking about seat height, it's also key to think about individuals who are non-ambulant and those who are hoist transferred. And then what we're thinking about then is actually their foot plate height. And we need to make sure that the feet are adequately supported, because even in sitting, we've got 19% of our body weight going through our feet. So suddenly if we don't support the feet and get that leg rest and foot plate height correct, where does that 19% go? Suddenly you could have 94% of an individual's body weight just going through their buttocks and thighs. And then we're wondering why things like pressure injuries are happening. So this is where things like height adjustable foot plates can be utilised, especially for maybe individuals who have a longer lower leg length or a shorter lower leg length. We might need to height adjust that to be able to support it and distribute that weight as equally as possible. And then we have the armrest height or the arm height, and this is not only key for individuals who can still rise to standing because it gives them that foundation to be able to push up and out of the chair, but it also encourages repositioning within the chair if somebody needs to just relieve that pressure period of time, or if somebody needs to just reposition the pelvis after transferring into the back of the chair. It gives them that foundation to be able to shuffle within the chair and reposition, but also gives them the optimum upper limb positioning for activities as well. And things like trays and that can be fixed to the armrest to be able to encourage hobbies and occupations and interest. It's worth mentioning here though that arm support can relieve tension in the neck muscles, but it should not be used to support the trunk and achieve trunk alignment. If somebody is using the armrests for trunk support, what we might find is them digging the elbows into the back of the chair or clinging onto the arms of the chair. We need to take it a few steps back, go back to the pelvis, go back to the trunk, and make sure that they're adequately supported before then looking at the armrests, because they're not there to support the trunk. That's just really key to mention. Of course, if somebody is clinging onto the arms of the chair, then they lose that upper limb movement, they lose that freedom of movement to be able to engage in activities, and suddenly their function and independence is impacted significantly. So this leads us into why we're doing this presentation. So it's critical that a seating prescription is appropriate for the individual and it meets their needs. But it might not be overprescribed or unnecessarily complex either. So there is such a thing as overprescribing, especially when we're thinking about functions like back angle recline. If it's not suitable for the individual, then it just should not be available on the chair or easily adjusted within the chair. And then the care plans then will offer that guidance going forward to help the individual, to help the support network on safe and appropriate use, which is key to that consistency as well and compliance with equipment. Okay, so let's try and put some of this into action. Hopefully we're back on screen now. Yeah.
Okay, so what we're going to do now is just have a little look at what Rebecca's just been discussing in terms of theory and apply that in practice to the product, to the chair. I've got a selection of the chairs here from the Careflex range, ranging from mild to moderate to more complex in terms of postural support. But the chair I'm going to focus on today is going to be the multi-adjust. Now, I'm not going to show you the mechanics and how I'm adjusting the chair. If you need to see that, we've got loads of information online at the website. We've got lots of how-to videos that will give you a lot of detail on how I'm adjusting the seat depth and the seat width. What we're going to focus on is the potential for harm, I guess, if these things aren't set up correctly.
I think we just really wanted to emphasize that it's more than just comfy seating. I think that's a term that gets thrown around quite a bit in terms of comfy seating. It's actually a medical device. It's a prescriptive piece of equipment that's a key part of their care plan. So it's got to be treated as such. It's got to be treated as important as somebody's medication plan, because if it's not used appropriately, then the detrimental effects could be significant for them.
That's right. So just a very quick overview of the chair. It's the multi-adjust. It's tilt and space with back angle recline, elevating leg rest, adjustable foot plate. We look at the adjustment of those features and the theory that applies to the adjustment of these accessories a little bit later in the presentation. What we're going to look at here, though, is seat width, seat depth, arm height, and seat height, seat width. I've lost myself. Height, width, and arm height. Yeah, it's the old age. So what I'm going to do first of all, I'm going to set the chair up, I guess, inappropriately, just to give you an idea of what can go wrong. So I'm going to be the model. I'm going to get my model involved. I'm just going to set the seat there a little bit longer. What I can do with the multi-adjust to make things a little bit easier for you to see, I can remove the arm. Get Rebecca to have a seat. I'm just going to push right away to the back of the chair. You can see just what's happening here. Okay, if we're trying to achieve, I think you said, was it two fingers to straighten the calf. If you look at the angle here, we can't achieve 90 degrees. Pushing Rebecca's legs forward, she's going to become what we call chair shaped. So what's going to happen is, if you try to bring your feet onto the foot plate and you're going to shuffle forward slightly, we're going to go into that posterior tilt. So what I'm now going to do, I'm going to hoist Rebecca out. I'm going to ask Rebecca to sit forward with me. As we said earlier on, with seat depth, we're not going to teach you how to measure this morning. We've got, again, loads of videos online that'll give you more advice on that. So I'm just going to adjust the seat depth slightly. I'm going to sit back here.
Yeah, do you want to make it, is that as short as it goes?
We go as short.
Yeah. This is why it's really key when we're talking about seat depth. I mean, it's quite hard to make it too short. Oh, I don't know, but okay. But if we're talking about seat depth, and my pelvis is right at the back of the chair, I don't have any damage to my body system that I'm aware of. I've got good trunk control, good pelvic stability, but actually what I'm doing is increasing my risk of secondary complications just by the setup of the chair.
Inappropriate.
Yeah, suddenly, I mean, we were saying about having a 2-finger gap between the knee. I can fit almost 1.5 hands in behind my knee. So that seat depth is way too short for me. All we're doing is increasing the pressure at the back.
We'll talk a bit about pressure care towards the end of the presentation as well. And
what it's also making me do is, because I'm feeling unstable, I feel like I'm being pushed off the chair and going into this anterior, I don't know if you can see the lumbar lordosis increase in there. I'm going into this anterior pelvic tilt to get myself stable within the chair, because I feel like I'm coming out of the chair. And likewise, when we showed you where the seat depth is too long, it was pulling me down into a posterior pelvic tilt just to be able to get that proprioceptive feedback through the feet. So I don't have damage to my body systems. I don't have any presenting postural challenges, but simply just from the chair setup, we've created those significant posterior pelvic instability just from the setup of the chair. So thinking about our individuals who already lack strength or have abnormal reflexes and muscle tone, to actually the effect then that there's something as basic the chair setup could have on their posture is huge.
It's critical.
Yeah.
So we'll look at seat width adjustment, and to do that I need to pop an arm back on. Again, if you need to see how I'm doing or what I'm doing in a bit more detail, how-to videos online.
So if we look at it a bit as the seat width has been too wide for me now, and we're talking about lateral stability within the chair.
I'm just going to leave the arms loose so I don't lean on them. Do a little bit more seat depth, just to make you a little bit comfortable.
So we're talking about seat width and the ability to, if we turn to the camera, the seat width, and actually we've suddenly got, again, 2 hands either side to be able to shuffle within the chair. Now we naturally seek support. We naturally seek proprioceptive feedback to feel stable on the supported surface. So by allowing that movement and to shuffle, and I'm trying to get that support through the hip, and then suddenly I've got this pelvic obliquity, so one side is higher than the other. I've got a pelvic rotation as well because we haven't got that lateral stability. So that's why seat width is really key. And of course, seat width, if it's too narrow, we've then got pressure care issues then as well, because we're compressing and
again, sometimes if it's too narrow, when you're hoisting somebody into the chair, they'll hook up on one side and you'll have a little obliquity happening.
Yeah. So that's seat width, that's why it's so key, because we don't want to be able to give anyone that room to shuffle within the chair.
You're looking to sit in the most energy efficient way, aren't you, really?
Yeah.
And that's not always a healthy way to sit.
Yeah.
So to adjust the seat width, I'm just going to bring this in I like a snug fit. You sit midline there.
Yeah.
Okay. So just to get a hand there, just tighten that up. On the chair, we've got measurements just on the brackets so that we can make sure that we've got equal width. Just want to lock that off there. How does that feel?
Yeah. And when I mentioned before about seat width, obviously we can be really prescriptive about this, and I'm sitting in a gold standard position.
Yeah.
Of course, we're going to work with individuals who can't achieve this. So if we are working with somebody who maybe has a windsweeping deformity, maybe I should have worn some pink trousers, you could see.
Yeah, lighter colour trousers.
So you can see, actually, we no longer need to, we can't simply just measure. If somebody's fixed in this windsweeping deformity, we can't correct them. We need to accommodate them within the chair. We can't simply now measure hip width. We actually, because if we measure hip width, what we then have is we've got risk of injury to the knees as well, because we're going beyond the chair. So we need to try and match the seat width to that, to support in that position. And you can get things like extended lateral pads and things. If
we do extended lateral pads. So what you
can
do in this chair is we can actually mirror or accommodate you just by twisting the arm.
When I said about we can have different seat, we can use different angles on the armrest to get different seat width from front to back and from left to right. So we're actually angling the arms on there. You can use angling. And likewise, if you're working with individuals who will maybe have larger body size, they've got extra padding in the gluteal region or the hip region, we can then open it up at the back to be able to accommodate that, but still keep it in midline at the front as well. So lots of different options for seat width, but still really key seat depth, seat width.
Yeah. Critical, you've got to start, especially with that seat depth. It's got to be right, otherwise you're going to cause issues as we use the chair. Yeah,
and then when we said about seat height then as well, if you imagine that I am non-ambulant and I'm hoisted for transfers, and if we didn't have the foot plate at the correct height, at the moment my feet are quite nicely supported, but if we didn't have the foot plate, what you might find is foot plates on top of bookshelves, there's paperweights and wardrobes, but if that wasn't there, I didn't have that foot support, then again, what you'll see is regardless of somebody's regardless of somebody's postural challenges or their presentation, If the seat height isn't correct and we're seeking that feedback, that proprioceptive feedback through the feet, and going in again into that sacral sit-in, into that posterior pelvic tilt, just to be able to get the feet on the floor. So it sounds really basic, but actually it's key, it's critical, as the first step of the prescription to get the chair set up for the user. Yeah.
That seat width.
Really key parts. Can't reiterate that enough. If you've joined our webinars before, I'm sure you've heard a lot of that spiel as well, but it's really, really key.
It's important.
It is, yeah.
Critical.
Okay. What I'm going to do is get at the next part of the presentation. Hopefully, again, everyone can see that. So what we're going to move on to now is some of the key functions that can be prescribed as part of the care plan and the individual setup. So we've got tilt-in space. Now, tilt-in space is where the whole seating system is tilted while the seat to back angle remains the same. So that means it doesn't alter the user's hip and knee angles because the whole seating system tilts. It can help to improve pelvic stability by supporting the pelvis at the back of the chair without affecting those critical angles for sitting. It can promote safety by preventing the user from sliding down the chair or even out of the chair. It can assist with head control by utilising the effects of gravity. And it can open up the shoulder girdle as well. If somebody's got a really kyphotic flex posture, then if it's suitable for them, it can be nice sometimes to be able to open up the shoulder girdle using the effects of gravity to do that. It can promote energy management by bringing the individual into a resting position for a period of time, which allows them then to recuperate before returning upright with activities of daily living or occupation, for example. It can assist the support network as well with hoisting and positioning, because by putting a slight tilt on there during the movement and handling, gravity can bring the pelvis down into the back of the chair. So there's a reduced dependency and effort needed by the support network. There are options as well for a forward tilt, where it can be considered for users who are maybe able to stand, but just need an extra bit of assistance or prompting to come up into standing. And that can be used as part of a rehabilitation program. Now, tilt-in space should always be prescribed responsibly. We have to make sure that it's safe and appropriate for the user. And we need to do a comprehensive seating assessment, of course, and an assessment of their risk as well. Where needed, we might need to seek some advice as well from the multidisciplinary team, maybe from speech and language therapy, for example. Because there are times when tilt-in space can be contraindicated, or its use needs to be fully risk assessed and very closely monitored. So we'd need a comprehensive assessment for the following users. So individuals with swallowing difficulties, maybe individuals who have pooling of saliva. We need to be really mindful of the risk then of aspiration or silent aspiration. Those who maybe need the use of a tray for communication, maybe it's critical that they have a tray that remains level for communication. But of course, if the tray is attached to the arms and we tilt in, then that tray is going to tilt too. We also need to be mindful of those who have catheters, because if somebody has a significant tilt and suddenly the catheter is higher, we can obviously get backflow then as well. So it's really, really important that we make sure the tilt-in space is safe and appropriate for the user before we prescribe it. Because don't get me wrong, it's a fantastic function, but it's got to be used appropriately. Next, we have back angle recline. So this differs to tilt-in space because it adjusts the seat to back angle. So the user's hips angle, so the range of movement and the hip angle is going to be affected as we open up the seat to back angle. It can help to promote comfort and relaxation and energy management. It can open up the hip angle to help with any pain or discomfort that might be associated with hip joint problems or reduced range of movement, for example. It can reduce abdominal pressure for users with obesity or a pronounced abdomen. And it can also help to relieve hamstring muscle tension as well if the leg rest is elevated. But it's the same with tilt-in space. Back angle recline should always be prescribed responsibly. We need to make sure that we have a comprehensive assessment of posture and risk. So if an individual has, I guess the key thing to remember about back angle recline is that it's critical that somebody has that pelvic stability or appropriate pelvic support before using back angle recline. I guess that's the key take-home message here. Because if somebody has pelvic instability and suddenly somebody goes in, even with good intentions, but they see a handle and they just open up the back angle recline, so they think it's going to be comfortable. But if they have pelvic instability, we can actually encourage a posterior pelvic tilt. We can cause sliding forward or even out of the chair. We can increase the shear and friction forces that increase the risk of somebody's pressure injury. But it can also exacerbate abnormal movement patterns. So somebody with an extensor thrust, what you might have seen this out in the field, but if we don't have that pelvic stability first and we open up that back angle, open up the hip angle, and you'll just see somebody's tone shoot through the roof, and you'll see that extensor thrust coming out of the chair, and then we lose all that postural stability that we've achieved elsewhere in the prescription. So back angle recline, and again, it's probably one of the functions that I see that's most inappropriately used. Yeah. Would you agree, Les?
Yeah, it can cause us problems, and what's important to mention here as well, from just like a holistic point of view, is that we cover a lot of this as part of the handover when we set up equipment, so the carers understand how equipment works and understand why we've set back angle recline and why it shouldn't be adjusted. Again, cliche I'm always using it, the devil is in the detail, and that initial setup for somebody is really, really key.
Yeah, and it's really key that we communicate that setup through the care plan, like you said, and that handover, so that regardless of who was supporting the individual to use that chair, they've got that baseline, and they've got that care plan to follow to make sure that use is consistently appropriate going forward, and we don't then revert back and cause any secondary complications. One thing that we do find quite useful, again, there could be consent issues, we might need to think about best interest, or up in Scotland, I believe it's guardianship, is photographs alongside care plans. What's the saying, a picture says 1,000 words. It's a really helpful visual guide then to make sure that setup is, every time that chair is used, that it's replicated within the setup. Okay. So tilt in space and back angle recline are actually really good functions that can be used in conjunction when we're thinking about pressure care. When they're used together, they can help to redistribute pressure throughout the body segments. And if back angle recline is required to maybe accommodate reduced hip range of movement, so we need to open up, maybe somebody lacks, they can't quite get to that 90 degrees at the hips, they need to open up the hip angle to accommodate that. Actually, if we use tilt in space first, a slight tilt in space in combination before opening up the back angle recline, we can help to reduce those shear and friction forces. And again, when we visualize that, we can just show you what we mean when we have a look at the chairs. Okay. Of course, there are manual chairs where you can use the levers manually to adjust these settings, but there's also motorized actuations as well, which is an electronically powered seating system that uses a battery system. So that means that the system can keep working as the chair is moved around. And what this does is that it can increase the independence if an individual is able to independently use the chair and has the competence to, and obviously the cognitive awareness to be able to do that appropriately. It can also assist support network as well with repositioning, especially when moving and handling users who might have increased body size and weight, easing those care responsibilities and effort. There's also the option of pro controllers.
And environmental controls as well, if your patient or client's got the function already at home.
Yeah, so if somebody maybe has a tablet system where they're controlling, they can be integrated into that. And then there's an auto tilt actuation as well, which enhances the standard pressure management functions that are already built into the chairs. What it does is it moves the chair through a half degree of tilt at short intervals. It can promote independence for the user, because it means that maybe they don't have to have regular calls to the house to achieve that change of position. And it can also reduce the time that's needed for manual repositioning as well. Okay, so now we're moving on to, so that's a lot of information, but I just wanted to keep running through the theory of this because it all kind of merges into one another when we look at when we look at the practical.
It's a system approach, isn't it?
Yeah, it is.
You know, one accessory and one function depends on the correct use of another.
Definitely. Yeah. Okay, so postural support. When we talk about the key principles of seating, we obviously had comfort, function. The third one was postural management or postural care. If a person has the inability to sit upright, then this can impact on their quality of life. It can result in decline in their overall health, which is primarily reflected in altered physiological function. So an unsupported trunk will also require more effort from the individual to be able to maintain erect against gravity. So then what we might see then is fatigue and discomfort as well. And the aim is to fully support the pelvis and the trunk, align the spine as much as possible. Of course, we can look at gold standard here, but in reality, it's just about the optimum position for the individual to reduce that risk of postural deterioration and pressure injury. Just visually, if you can see in the x-ray there, the individual has scoliosis. You can see the S-curve at the spine. You can see the rotation happening at the ribs as well. And it's pretty self-explanatory that this kind of postural deformity will impair on their respiration, their swallowing ability, making sure their eating is safe, and eating and drinking is safe, their digestion because of the compression that's happening on the internal organs, cardiac efficiency, and even endurance. It's quite significant and quite serious, but it's important that we get this message across because, as I said, it's more than just comfy seating. This is actually about reducing the risk of serious health complications like this happening. It's about identifying risk and getting equipment in a timely manner, but then also using them safe and appropriately to reduce the risk of things like this happening. It's believed, those of you who work in learning disabilities, it's believed that around 52% of individuals with a learning disability die prematurely from respiratory related conditions, which can be directly impacted by their posture. So yeah, we need to get the seriousness of this across as well. It's not just a webinar for the sake of a webinar. We actually really need to make sure that people understand that the setup is really, really critical to protecting the individuals that we work with.
The setup is just, it's the vital ingredient in the recipe, if you like, for the successful use and intervention of the chair.
Yeah. So one of the options that is available for trunk support, one that you might come across within special seated world, is a waterfall back, which consists of a lumbar, a thoracic, and a head section that encourages trunk alignment while still promoting comfort. And when we have a look at it in the practical session now, you can see actually how it can be useful for somebody with a increased thoracic kyphosis or somebody with a lordotic posture. Then we have a contoured back, which gives just gentle lateral support and feedback for the upper trunk. Maybe offers a bit more alignment than with a waterfall back, but still comfortable. It can centralize the posture with those contoured pads, but still allow dynamic movement. It's not restrictive at all. And this could be indicated for users who present with limited sitting ability, either due to weakness, abnormal muscle tone, or fatigue.
It's that kind of prompting solution to lateral support rather than kind of enforcing. Yeah,
it's that balance, because we don't want to be rigid with the prescription. We don't want to restrict individuals, and we certainly don't want to limit their independence. We still want to prompt active engagement from those core muscles as well, so that they are continuing to develop and they don't lose that skill. Use it or lose it, as they say. And then we have lateral support, which are external, adjustable, removable lateral pads that are a bit more firm in terms of the thoracic control that they offer. I'm thinking about height, independent height and width adjustment to get that, to get that postural stability.
Support.
Maybe somebody needs 2-point support, or if somebody has a scoliosis, they maybe need a 3-point lateral support. Again, we can't go into much detail because we've only got 45 minutes with you, but it gives that firmer trunk. And these are a key part of the prescription as well, because you have to be really mindful of how lateral supports are used.
I always touch on these in the practical now as well.
Yeah, just to show you actually how they can be used inappropriately, and if we are going to prescribe them, we need to monitor the use of them. Another key part of the chair that actually we wanted to focus on during this webinar that can be used inappropriately is the leg rest. They are important because they help to encourage comfort, lower limb alignment and pelvic stability. Things like in the image here, you can see a channel leg rest, just might help keep the lower legs in midline. You can get negative angle leg rest that can help accommodate limited knee range of movement. So if somebody's got tight or shortened hamstrings or knee contractures, they might need that negative angle to be able to flex the knee or accommodate the knee in that position. Then also W trough. So those of you who work with nighttime positioning might see something similar, that W trough for maximum stability and alignment. And then we've got elevating leg rests, which obviously is quite a common part of specialist seating, and they can be used to lift the lower legs to a relaxing position. But this is where, again, another take-home message, they should only be implemented if the user has appropriate knee range of movement. Otherwise, it can cause pain, a posterior pelvic tilt, sliding down the chair and increase those shear and friction forces that increase the risk of pressure injury. And again, we'll reiterate that in the practice, so you can actually visualize what happens if we use a leg rest elevation and somebody does not have the range to do that. So just to say again, that they should only be used within the ranges tolerated by the user based on their knee range of movement. It's essential that that leg rest elevation is prescribed carefully. And like Les said earlier, there's a clear handover of how to utilize it appropriately, or not at all. If it's not suitable for someone, then it should be very clear that it should not be used.
You know, and there are instances, what we look at with the practical are very much kind of off-the-shelf standard items with us, but we have a tailored solutions option as well. So when we say sometimes we can't use the leg rest, we may sometimes take the leg rest off completely to accommodate perhaps a really acute contracture.
Yeah, something like a hanging foot plate.
Yeah, the hanging foot plate. Again, if you refer to the website, you'll find a lot more information on our tailored solutions offering as well.
And then we have the foot support. We've already said that the feet, even in sitting, take 19% of an average person's body weight. So it's really critical that they are supported appropriately, because we naturally seek that proprioceptive feedback. Things like angle adjustable foot plates can help to correct positioning. So if we can correct it to neutral, then great, but we might need to also accommodate any fixed postures, such as a foot drop, or if somebody has a fixed flexion deformity, maybe they have a dorsiflexion deformity, and we might need to then think about a encompassing soft pillow that just supports the whole foot if somebody has that deformity, rather than actually a firm pad.
It's a compromise again. Another word we use a lot of is,
yeah,
you know, sometimes we can't get that even support, and just we need to accommodate.
Yeah. And then finally, in terms of the body segments, we've worked our way through the pelvis, the trunk, the lower legs, and then up to the head. And I find the head actually one of the most difficult body segments to support, especially if you're working with individuals with maybe quite significant fixed kyphotic postures, where there's an extreme flexion at the neck, and maybe they're lacking that extension to be able to come back to neutral. So it's really key that we support the head, because that's what's essential for optimum physiological function and safety when we think about eating and drinking, that swallow function. But it's also vital for interaction as well with the outside world. So thinking about somebody's well-being and their purpose in life, their social interaction, their orientation within space, to be able to engage in functional activities, but or social activities if they're in nursing homes or care homes. And the aim is to encourage the head and neck to be in this upright midline position as possible. So things like the inline headrest, you can see in the image there, doesn't affect peripheral vision. You can still engage with the surroundings and with the outside world without any blocks to vision, but also hearing as well. And then another thing if we've got time to look at, but again, there's lots of information on the website. I realised we're going through a lot of information this morning, but we'll be sending out full presentations as well, copies of the presentation. Is an articulating headrest, and particularly useful for individuals with fixed kyphotic postures. So we can't correct the individual to the chair. We need to bring the chair to the individual and accommodate. Okay.
Okay, so we'll use the multi-adjust again to start with, and I think we'll start, Rebecca, with tilt and space and back angle recline. We'll just kind of demonstrate that if you've got a second. So tilt and space before Rebecca jumps in the chair, you can see the back to seat angle remains constant. Just get that good angle there. So as long as it's a good transfer into the chair, which is a webinar on itself, the transfer, that's all the carer needs to be concerned about, is getting that bottom as far back in the chair as we can. And we're away.
And then what you'll see is once we've achieved that pelvic stability, tilt in space won't alter. So my pelvis remains in the same position, hip angles, knee angles all remain in the same position. Whereas back angle recline differs in that we actually open up that hip angle.
So I'll just go there now.
Yeah. So I have good pelvic stability and trunk control. So back angle recline for me is something I can tolerate and I can still remain stable within the chair. But if we come back upright, if I didn't have that pelvic stability,
you couldn't just do what you just did.
If I didn't have that pelvic stability and I was prone to going into a posterior pelvic tilt, if I have abnormal tone, so something like an extensive thrust, if we don't consider the pelvic stability and we go straight in and open up that back angle, what we can see is that somebody would go down the chair. You might see individuals going into that extensive thrust, or we'll see them sliding down the chair, and suddenly we've got this big gap at the back of the chair. Yeah, we're at risk of sliding down the chair, but then also coming up because I'm unable to reposition myself. Yeah, we've suddenly got this crunching then with the abdomen
of Rebecca's head now, and now if you reposition yourself there. Okay, so it's really, really important. Unless your client can achieve that, we want to be really careful about using back angle recline. What we tend to do with back angle recline is set it and lock it. And there are various ways in which we achieve that on the multi-adjust. We use a locking lever. So tilt in space is just a lever. You squeeze and you adjust and you release where you want your client to sit. Back angle recline is a locking lever. So there are two actions. You need to release the lock, squeeze the lever, then adjust, then you'll hear it click, locked. Okay, so that locks that off.
While we're talking about back angle recline, another key thing to remember is when we spoke about laterals. Obviously, they have their place. They offer firmer thoracic control. They can help if somebody's got a scoliosis, thinking about 3-point support. So they do have their place. But if somebody, So thinking about back angle recline with lateral support specifically now, if that lateral support was positioned appropriately while I was sat upright, what can happen then if we use, back angle recline?
So you see with tilt,
doesn't alter.
You don't have a problem, but there's no issue. Okay, so if you're going to pop your arms back down, I'm going to give you a little bit of tilt. But look what happens to the position of the lateral where it's supplying support for Rebecca, and look at Rebecca's arms. I'm going to ask, but how comfortable is that?
Not very.
You know, you can see the arms are kind of rising up.
And then when we come back upright again, think about individuals who can't reposition, who lack that the trunk control. Yeah, that's squishing me there. Yeah, so and those laterals, and now when we return back upright, not in the place. So if I've got a scoliosis or a lean, I'm going to go straight back into it because they're not now positioned where they should have been on that initial setup. So that's just something we really wanted to get across during this webinar, was back angle recline.
And squishing people.
Yeah, squishing people. Yeah.
Okay, so that's tilt in space. Back angle recline.
I think leg rest.
We look at leg rest.
Yeah, it's an important thing to cover.
I look at leg rest and foot plate.
I'll take these out so we can see.
Do you want to take them away?
Yeah.
Happy with the arm off the chair?
Yeah. So just going back quickly to back angle recline, tilt and space. If the only goal that you have is for maybe energy management or comfort, then consider, what we're trying to say is consider that tilt in space over back angle recline initially. Of course, it's got its place if we need to open up the hip angle for comfort and things, and maybe just consider tilt in space before then looking at
and just quickly, as we did mention laterals, sometimes there's a compromise. Lateral may be, you know, the indication is that's the best sort of lateral, but it may not just be comfortable for somebody. So we could look at a contoured back. This is a contoured back of a hydro tilt chair. You can see the shape in the back of that. So that's going to prompt that midline position, as I mentioned earlier on, rather than the more kind of direct lateral support we just saw with Rebecca. So we can talk a limited range.
Yeah, so leg rest is another function that we've got to make sure if we're prescribing it, that everyone knows how to use it appropriately, because it's really dependent on somebody's knee range of movement. So I've generally got good range, my hamstrings are quite tight, but if I was to use a leg rest elevation, then I can tolerate that. It doesn't really impact on the rest of my positioning. So if Les just shows, I can tolerate that leg rest elevation. If I didn't have the knee range, we take it back down. So I don't have the knee range of movement. I've either got tight hamstrings or a contracture. That's all I can achieve. I can achieve that. Was it just 10 degrees beyond 90? But if somebody then was to come in and elevate those legs, because I can't physically extend, what's going to happen is we're going to go into that posterior pelvic tilt. You're going to see this massive gap there because I don't have the knee range to tolerate it. So all that's going to happen is going to affect all the other body segments and pull me down into that posterior tilt. And
we'll mention pressure care in a little while as well. And you think of the impact again on pressure care.
On the sacrum now.
You know, one of the objectives of pressure care is to spread pressure over as great an area as possible to get as much of Rebecca in contact with the chair as possible.
Yeah.
You look how much of Rebecca isn't in contact with the chair, that weight's going to be somewhere.
Got a gap behind there. So we've got heels, sacrum, apex of the thoracic spine, all taking my full body weight.
And that's pressure care being affected by the use or the inappropriate use of the chair, not understanding what happens when you elevate the leg rest of the foot plate. Also, if you do have the range, we sometimes need to accommodate for the action of the leg rest. So, for example...
So I corrected myself now, but even now there is still...
gaps here, okay?
Because the pivot point is different for the knee and for the leg rest. So we are going to get that bit of the gaps. We might need to then have when we said about height adjustability, thinking about seat height or foot plate height, it still needs to be able to accommodate that.
Just take the weight off there. So we can just drop that down. There we go. So that needs to be adjusted. Okay, the other thing we can do, being very mindful sometimes if somebody's got tight hamstrings, just look to do a little bit with the back angle just to take some stress out of the hamstring.
Yeah, somebody's got good pelvic stability, but actually you just need to relieve some of that tension on the hamstring. We can open up the hip angle
just
a little bit. Yeah, but we've also got a little bit of a tilt as well to keep the gravity of the pelvis at the back. So yeah, leg rest elevation's really, really mindful of actually a safe and appropriate prescription of that.
So if I let you out of the chair.
Mindful of times, we've got a lot of information. So we tilt in space, back angle recline, leg rest elevation and the laterals. Yeah, I think what we can do now is, as long as people don't mind, I know sometimes we do have a question and answer section, but if you have got any questions, pop it in the chat. And if we don't get around to doing it, we can contact people individually or send, if there's common questions when we send out the presentation, we can answer those. But I just wanted to quickly, because another, I think a sticking point with a lot of seating prescription is probably positioning aid. Would you agree, Les?
Yeah, there's a lot of confusion about what they're actually, you know, the primary purpose is.
Yeah. Because of course we're not advocating any form of restrictive practice. They are positioning aids. So I just wanted to touch upon belts and harnesses. So when they are implemented appropriately as positioning aids, they are critical to an individual's, especially complex postures. They're critical to their seating description and ultimately their quality of life, because they can help individuals to maintain a stable sitting posture. It can promote comfort and safety and enhance their physiological function. They can also help to reduce the risk of pressure injury through the effects of shear and friction. But there is, and I say this with lots of exclamation marks, there is a risk of serious injury or death if a positioning aid is used improperly or in ways other than intended. Anyone prescribing or using belts and harnesses, needs an appropriate level of competence and confidence, because that's essential for all those who provide, prescribe, implement and maintain belts and harnesses in both their function, adjustment, cleaning and operation. I won't read through all this, but there's a device safety information and there's a link for that in the references section that just gives a bit of background on that and some guidance going forward for anyone who's prescribing positioning aids. Not only obviously for safety for the individual, but actually for confidence with us for our prescribing as well, so that we know that we are prescribing it appropriately. As already mentioned, the provision of any positioning aid must be cautiously considered and risk assessed, because there are going to be certain circumstances when belts and harnesses can be inappropriate or contraindicated. So things to be mindful of are capacity to consent to it. So we need to think about consent issues there, think about respecting individuals' decisions if they do have capacity, but don't want the pelvic belt, and discuss alternatives. Some individuals, especially those with extreme involuntary movements or those who display behaviours that challenge, could be at risk of injury if they're positioning aids in situ, because they could struggle against the belt or harness. We obviously need to make sure that we're not restricting ambulant or active individuals and depriving them of that liberty, and again the risk of immobility and poor health could be increased as well. And we also need to be mindful of those with skin integrity concerns and make sure that there's clear monitoring and reviews in place, because it can increase the risk of injury if it's not used appropriately. I think one of the biggest things we see is them not being done securely enough.
Yeah, they need to be checked every time they're used, really. Yeah,
checked every time they're used, make sure that they are fitted appropriately, because if it's too loose, actually there's no point using it. It can actually cause more harm than good, because what you can see is increased shear and friction if it's not given that stability.
Especially something like a 4-point pelvic strap. Yeah. You know, that needs to be a snug fit to help provide the support that it's intended to for. Yeah.
So I won't run through it, I'm conscious of time, because I just wanted to cover pressure care at the end. But again, all this information will be sent out. It's just a bit of information on the different types of belts and harnesses that are available. The thing with positioning aids is that it's got to be the last resort. So we try least the restrictive options first, building our way up to the maximum control then that we can see with things like a groin harness, chest harness. Other accessories that are available are pommels, especially good if you're working with individuals with adduction issues or wind sweeping, just to help accommodate or hopefully correct some postures. And then we mentioned trays as well. We just need to be mindful of how a tray is used. But they can, even though they're good for activities, it's actually good for postural support as well, using V cushions. We've padded trays before, to open up the shoulder girdle, offer that upper limb support that we need. And then transfer arms. Okay, so just finish on pressure care then. So I guess the key thing, and Les will agree with this, thinking holistically, stop sharing this so you can see Les, thinking holistically, it's about a whole seating system. It's no longer the case that we can it's never been the case, but I think the awareness is coming, that people are accepting that we can't just put cushions on top of cushions and expect pressure injuries to resolve. It's a whole seating system approach, and we've covered a lot of those things already. Yeah. Seat depth are really key. Thinking about tilting space to redistribute pressure, a regular change of position, thinking about the chair within the full 24 hours as well, and achieving different positions throughout the day. But what we can add on top of that then is the water cell technology.
Yeah. You've just said about mostly everything.
Sorry, Les.
No, but just to
been working together too long.
No, just to reiterate, it's a system, and the effectiveness of the cushion is only as good as the setup of the chair, so that we achieve good weight distribution, so that we achieve a midline, so that lateral support is effective, so that foot support and head support. The cushion is a part of the system. Careflex all our seating comes as standard with a pressure care cushion. We call it water cell technology. And the principle of what we are attempting to achieve is the same with most pressure care cushions. Static cushions, not a dynamic cushion, a static cushion. And that's to absorb any high pressure point, probably your ischial tuberosities, and to spread that pressure over as great an area as possible. So what we have as the cushion is a four-way stretch, breathable fabric. Really critical component of the cushion because it allows the person sitting on the cushion to get the full benefit of the pressure care that lies beneath the cover. Then we have a memory foam, a high elastic foam, and water cells. So the four-way stretch does what it says on the tin, stretch and allows the bony prominence to be absorbed. Memory foam reacts to body heat and contours the body shape. So there's more of the person sitting on the chair in contact with the cushion. And the water displaces, just literally moves away from where the high pressure point is. So what happens is you get a high pressure point, comes into contact, absorbs the high pressure point, and the surrounding surface rises to spread that pressure over a greater area. That's called water cell technology.
Yeah, and it remains dynamic. So we want to see people like subconsciously, I guess, moving within the chair and changing the position naturally is something I think on average a person does every 7 seconds. We want to see that, but we don't want that to affect the pressure care either. So that the water cells is what allows it to be dynamic and change to those subtle changes in posture as well. Yeah. I
think we've just about come to the end of the presentation. We're running a little bit over.
Sorry, we could keep talking, sorry.
We will follow up with a copy of the presentation, a link to the training session, plus a pack of other little bits and pieces that we think will be appropriate to support the content this morning. So without any further ado,
let's see if there's any pressing.
Or we'll just have a quick look to see if we can take any of the questions. If you need to go, that's okay, you can go.
Hi Les, so we had a question. Can you set the back angle and lock on all of the chairs, as well as the tilt in space? Can that be limited to prevent the user over tilting?
Back angle recline, yes, we can lock. There's various ways we can do it. Very simply, on some of the chairs, we just undo the cable that connects to the gas strut. On the chair called the Smart Seat Pro,
you hide it away.
We hide it away. So if I bring the chair closer to the screen, the camera.
So you can set it to the angle that you want, and then you can.
So we'd set, it's still a locking lever. So I'd unlock, adjust, set and lock it off. But you may have an issue with carers or family members or siblings coming along and playing with the adjustment. So what we do is we unscrew the lever, 2 little screws here, take the top section off here and drop the lever inside. So in effect, what you then have is a tilt and space chair, which has back angles set to the individual's requirements. That was nice and easy, Jess. Any more?
That's great, thank you. And also, would that be the same for the auto tilt?
Auto tilt, you'd set the back angle recline, the tilt would regulate. You wouldn't be adjusting the back angle recline as part of the auto tilt function.
It's a motorized function. It's a programmed motorized function. So it does it automatically. It doesn't need any actual someone to adjust.
The tilt will go back to its 30 degrees, but I believe it'll only come forward to 12 degrees. So it's not going to bring somebody upright because we perceive that as being a possible risk.
Thank you. Also, is there a specific angle that causes backflow of catheters, and how can it be managed if tilt in space is needed posturally?
Over to Rebecca.
It's all about the position of the catheter in relation to where the tilt is. I mean, I think it's going to be very rare that you're going to be tilting somebody back far enough. But it does happen because maybe some people have fixed knee contractures. So they are in that, the knee is going to be fixed higher when you tilt them back. I mean, again, it's a balance. I can't, if somebody needs tilt in space, then something like 5 or 10 degrees should be sufficient to still get gravity to impact on the pelvis without then lifting the thighs so that the catheter is higher. So if you imagine that's the knee and that's the pelvis, so the catheter is actually, it's going to be very rare that you can be tilted back that far, but it was just something to be mindful of. You can't see it happening.
And it's an example of compromise. And, you know, it's the type of information we need at the assessment process. You know, we can then build that into the handover and kind of reiterate how important that tilt and space angle is. There are ways in which we can monitor little what we call tailored solutions, in which we can put little guides on a chair to help with, this is the optimum angle that you need to be tilted back at. if you need a bit more detail on that, drop me a line. And
and specific client. I mean, if there is a specific client in mind that individuals ask that question, then get in touch and we can have a chat. I mean, in terms of the research, something as simple as 5 degrees tilt sometimes offers enough to be able to achieve pressure redistribution all the way up to 20, 25, 30 degrees tilt. So it does depend on the individual, but actually we've found that even just a slight tilt, 5, 10 degrees is enough to achieve the postural change that we need, and that shouldn't then impact on the catheter. But if there is a specific individual in mind, then get in touch and we can chat in more detail.
That's great, thank you very much. We have just had another question come through. If used daily, what is the lifespan of the cushion?
It's a piece of string.
Yeah, it's another cliche. I like the cliches. How long is a bit of string? So if I give you a worst case scenario, so there's somebody with involuntary movement or very uncontrolled, unbalanced transfers into a chair.
Maybe somebody with Huntington's, who has maybe literally the ones who slump down into the chair on transfers, and that's a repeated thing.
So
every time
the transfer is very kind of, and then we get to hearing it. Yeah, so that coupled with perhaps the cushion being damp a lot of the time for obvious reasons.
And the Craig movements within the chair, then the repeated.
So what you have then is the cover on the foam, which is continuously damp, the dusty residue of the liquid moving all the time.
Not friction.
That's not a very common instance, but that could be a year, 12 months. Typically though, I mean, we are still supplying components for chairs which are 10, 12 years old, and the cushions are still intact. So
Devon water.
Yeah, it's Devon water, yeah. It's also a modular design to the cushion. So if a water cell breaks, which is not very often, we'd replace that single component. If there's a rip in the cover and there's no contamination, we can just replace the cover. So it's quite a modular design. Hope that answers the question by not really giving an answer.
That's great, thank you, Les. I think that's all the questions we have. If anyone else wants to put any in the chat, that would be great. And of course, you are welcome to email at info@careflex.co.uk at any time.
Thank you all for staying for so long. Sorry we've run over a little bit, but we could keep talking for the next 2 hours.
Well, you could.
I could, yeah.
Okay, so at that point, we'll bring the meeting or the presentation to an end. Thank you for attending. We'll see you all shortly.
Yeah.
Thank you.
Thank you very much.
Bye-bye.
Bye.
Bye.